Day tribute, and as you can see, we are sporting our respective shirts. Y'all know who the winning team is going to be tonight, that's for sure. So we've got Dr. Jason Souza here in the house in the Cosi Talks hot seat. I'm going to give you guys a couple of minutes to jump on board. For those of you who are watching the replay, thank you again for your support. Love getting your comments after the show's over. So if you are watching the replay and you have any questions about osseointegration, the OPRA Implant System, and you want to direct them to Dr. Jason Souza or to myself, go ahead and put them into the comment section. So we're going to give you guys another minute. But in the meantime, Dr. Souza, cheers.
Cheers.
All right, there we go. All right, and I see a couple of people jumping on board right now. As you come on board, guys, don't be shy. Let me know who you are, where you're from, and what's in your mug. So if you guys think that Dr. Souza looks familiar, it's because he was on the show at exactly this time last year for last year's Veterans Day tribute, talking to us about targeted muscle reinnervation. So really excited to have you back on the show again this evening.
Yeah, thanks for having me.
All right. All right, guys. There you go. There's Scott from West Virginia with his bottle of water tonight. All right, we got a couple more people jumping on board this evening. So far we're good with the no echo?
Yeah, I think so.
We're good. Hey, Scott, can you do us a favor? Can you hear both of us okay? Any problems with audio? While we wait for other folks to jump on board. All right. Sorry, sometimes there's like a lag in the chat section. There we go. All right, what's up, Kevin? Watching in from the YouTube channel. So guys, those of you who are watching, you can also watch the replay on my YouTube channel under the name Cosi Talks, just as well right there. All right, good to go. Comments are a touch slow this evening, so let's just see what's going on. All right, guys. Hey there, Tom. Tom is my runner. Tom, how was your marathon? I think you ran the New York City Marathon. And I don't think it was his first time running a marathon. He is my resident, right? He's an above the knee amputee. Yeah, we got compa. There we go. There's my comments. All right, there's Benny. There's that's the Marine Corps. So we got the Marine Corps listening in right now. So Benny is here. We got compadre listening in. Thanks for joining in. We got Emily from Central PA. Better than the CMAs and the debate. That's very good to know. We won. We're beating out the CMAs and debate. We're setting the bar high tonight. What can I say?
I don't want to comment on the CMAs, but the bar.
It'd be scarier to comment on the CMAs, I think. All right, guys. All right, we're going to give you just a few more seconds to jump on board. We got Rob coming in from Indiana with his blueberry coffee. Cheers to you. All right, guys. Chuck is here. Tom, oh, it was good. Tom, what was your time? Just so I can be jealous. Hey there, Harsh. Guys, I had the most amazing time at the Mission Gate Discover Your Possible event this past weekend. I was able to do some keynote speeches there. Really amazing getting to meet some of you like Harsh and his family there this past weekend. All right, guys, we are going to go ahead and get started. So for those of you watching for the first time, welcome. My name is Cosi Belloso. I'm a physical therapist, amputee specialist here in Tampa, Florida. And with me here tonight is Dr. Jason Souza. So I'm going to let Dr. Souza introduce himself.
Jason is fine. All right, now go. So I'm clearly on the Navy side of the house here. So actually, I think the echo is back. Can you check your echo thing?
Yes, I will check that.
All right. So I am a plastic surgeon. I spent 6 years at Walter Reed on active duty, and then transitioned here to I'm in Ohio. I'm at the Ohio State now. I've been here 2 years, and it's been a great fit for me. I have a little bit of a unique practice in that my entire practice is lower limb reconstruction. Occasionally, I'll do an upper limb reconstruction or amputation, like usually a transhumeral or shoulder dysartic or forequarter or something kind of more proximal. But it's an entirely extremity-based reconstruction practice. And so I would say that half the time we're trying to salvage limbs, and half the time we are either taking limbs off or trying to make them work better, regardless of whether that you've had an amputation or limb salvage. And right now, half of my practice is cancer-based reconstruction and half is trauma-based reconstruction. And then one of the things that kind of brought me here to the Ohio State, I have to keep remembering that it's somewhat new to the game, is that there's an interest here in supporting a military medicine program that's designed to kind of offer the kind of expertise in reconstruction that exists here for cancer reconstruction, and be able to apply that to our veterans, or offer that to our veterans. And so that's kind of my background. One of the things I think that maybe makes our practice a little bit unique is that we start with pain and we start with function. We don't start with limb salvage or amputation. And oftentimes I think that gets us to a better outcome faster than if you go down say a limb salvage pathway or go down an amputation pathway, either due to a desire to kind of keep a limb as long as you can, or a desire to kind of simplify surgery. And so the other thing that's a little bit unique, we just had a patient come through who's just an incredible guy, but we end up doing 70 hours of surgery, 5 long microsurgical cases to keep his knees and keep his elbows. And so rather than be a quadrilembar amputation or amputee at a transhumeral and above knee level, we were able to use all of our surgical sophistication to keep him a long BK and a long transradial. And so we are somewhat unique, I guess, in that we are not afraid to kind of add sophistication to keep length rather than kind of do what's oftentimes simplest. And so that's the, a rambling background.
No, we love the rambling backgrounds. And guys, we had a bunch of people that just jumped on board in the past minute or two. And I just want to say, this is our early Veterans Day tribute. I have so many of you out there who are veterans from all branches of the military. I know Benny's right there and he served in our Marine Corps. My own father was a veteran, 82nd Airborne. So he jumped out of perfectly good airplanes. So guys, I do want to give a shout out tonight to our veterans. And if you are, we would love to hear from you. So if you are a veteran, I would love to hear, your name, your rank, and where you served and what was your job, just so we can thank you. Emily's like 70 hours. I know that's a lot of surgical time.
Yeah. I mean, it takes a certain type of patient to take that on. Right. And we were totally honest about what we were getting into, but he had kind of lofty but realistic goals. And actually, he flew from fairly far away to kind of embark on this. And the first thing I said when I saw him, because we saw him before, while he had necrotic limbs, he had gotten very sick with sepsis and had necrotic limbs from vasopressors. And I looked at him and I said, this is going to sound funny, but I'm excited about what we can do. And he said, well, then I'm coming there, because everyone just looks at me and says, oh, poor guy. Right. And so that's a lot. And that's a little bit of a unique or extreme case. But the reality is, I think in this amputation space, we live in an interesting place where we put a tremendous amount of sophistication and dollars and time into keeping limbs. And then if it's deemed that a limb is not salvageable, there's often or too often very little thought, time, or energy put towards optimizing the amputation.
Yep.
One of my goals right now is to try to shame the surgeon who prides themselves on doing the fastest amputation, because while that means very little OR time, it means a lifetime of challenges, right? And so luckily, I think there's more and more interest in this space. And getting back to kind of the veteran theme, you have to kind of see it to know it's possible. And one of the greatest gifts I had was to be able to spend time at Walter Reed working with some of the best surgeons, nurses, staff that I've ever worked with, but then working for the best patients in the world, right? And patients who refused to accept amputation surgery and prosthetics that hadn't really advanced since the Civil War and said, no, that's not good enough for us, right?
Yep.
it's amazing that in such a short period of time, we can go from that to, you cannot watch a commercial now without seeing someone with limb loss, right? And they're not the focus. It's not the focus of the commercial. They just have been fully embraced. This community, I think, has been fully embraced, and I think we owe our veterans, our wounded warriors, debt of gratitude to kind of getting us there. Because it makes for a much more exciting landscape to work in when our patients are oftentimes further ahead than the surgeons.
No, and it's interesting. Just in the 23 years that I've been practicing, and when I first started out, everybody had a mechanical knee and a satch foot, and now 23 years later, microprocessor is a very common word. TMR is now being discussed. I know all of my viewers, a lot of my viewers will email me and saying that they are bringing this information to their surgeons, and now osseointegration. So guys, tonight we are going to be talking about osseointegration. This show is sponsored by Integrum, and I cannot thank them enough for their support this year. It's kind of a new topic, but it's not a new topic. It's definitely growing a lot in the US. Integrum makes the OPRA Implant System. So it's a very particular type of osseointegration, and osseo-anchored bone prosthesis is what they like to call it. And it is the only FDA-approved osseo-anchored device here in the United States, and it's been approved for above-the-knee amputees. Globally, Integrum has been doing osseo-integration, or the OPRA Implant System, for all limbs and all levels at this point, including even a thumb, correct?
Yeah.
Like a thumb implant. So it's kind of amazing. So Dr. Souza is on loan from us from Integrum to talk a little bit about that. So did you start your osseointegration work in the military or afterwards? How did you come across working with OI?
Oh, well, that's funny. I started before the military.
You have to back it up a little bit. You're gonna have to back that up.
So I was thinking about osseointegration when I was a resident. And at the time it was kind of viewed as the quote unquote holy grail, because all of the things that we were interested in doing with TMR at the time, TMR, when I was kind of early working with Greg Dumanian at Northwestern with TMR, it was all upper extremity amputation. And to really realize the benefits of anything we were doing with nerve transfers to essentially better control the prosthetic, you have to wear the prosthetic. And that certainly had that's a challenge at all levels, but there's a huge rate of abandonment just because of how hard or how much time and energy it takes to put an upper extremity amputation on, and then how limiting it is oftentimes due to the socket. And so we started getting interested in osseointegration before it was at all available in the United States. And so I'm not a huge, put it this way. Unfortunately, I had to experiment a tremendous amount in a huge range of animals to try to make this work. And I remember thinking, if only we could get this into humans, we could actually, I think they'd behave better than the variety of animals we were working with. And when I transitioned to Walter Reed was right when John Forsberg and Kyle Potter had really kind of started launching the program. And ironically, the very first, is either the very first or the second patient that we operated on at Walter Reed was a patient that I had operated on with Dumanian in Chicago. And we had done something called an angulation osteotomy, which is essentially putting a bend in the humerus to try to give you something to suspend to as a prosthetist. And he had done better. We had done TMR, but really was still very limited. And so he was one of our first transhumeral osseointegration patients.
Wow. So guys, we're going to just back it up just a little bit. Many of you who've watched the show this year, we've had several shows on osseointegration, the OPRA Implant System. And I would encourage you go back to my YouTube channel and you can find those live videos there. We've had some amazing special guests to also talk about the matter. So we're going to give you a brief overview. Casey is saying, Casey, what do you mean are you saying go Navy? Seriously, man? All right. And he's saying Dr. Potter did his surgery stage 1 in May of 2022. Hey, Andrea, we've got our local occupational therapist on board. All right, guys. So we're just going to kind of briefly go through OI and specifically the OPRA Implant System. So it was actually created by Dr. Brandemark back in the 1950s and 60s. He pioneered the technology of osseointegration. And what that basically means is osseo-bone integrating. So integrating metal and bone together, specifically titanium metal. And it was found that these two could fuse together quite nicely without any rejection, without any kind of issues with the metal implant. It actually led to the modern tooth implant that we have today. So Dr. Brandemark's work from the I always forget, it was the 1950s or 1960s, carries over 60s?
I think so.
Carried over into today. Dr. Brandemark's son is a surgeon, Dr. Ricard Brandemark, and he actually was the one who did the very first osseointegration procedure on a above the knee woman in 1990, if I'm remembering correctly. So that was the first time it was done on an amputee with the purpose of allowing the prosthesis to directly attach to the human skeleton, right? Am I getting all this right? You gotta keep me in check, because Army, sometimes we kind of go off the road. Right? So with the OPRA implant system, guys, and by the way, OPRA stands for Osseo-Anchored Prosthesis for Rehabilitation for Amputees. I still have to read that. I always just think OPRA. Okay. So the way OPRA works is you have a 3-part modular system. All right, guys. And I'm going to share the screen because I have just a quick video that just kind of really shows it nicely.
So far, there's a who's who of osseointegration represented in the chat room there with Potter and Forsberg.
Oh, oh boy. Sorry, guys, we got to fast forward it a little bit. I decided not to stay where I had put it. Okay. Okay. You gotta love technology. Okay, so first you have the titanium device that's implanted into the femur with the fixture. And then next there's an abutment placed on the outside, and then the prosthetic is attached directly to that fixture right there. Short and sweet video. Okay. It's a short and sweet video. It's just a 2-second video, but it's just basically to show you how it works. So you just have, it's a 3-part modular system. The first part is the fixture. That is the part that gets implanted into the femur in the first part of the surgery. Okay. And in that first part of the surgery, once the fixture is implanted and the skin is completely closed and it's allowed to heal. So Dr. Souza, how much time do your patients typically take to heal from that first part of the surgery?
Yeah, so we've largely used a 3-month window. That's what we used at Walter Reed. When we kind of adopted the protocol from Dr. Brandemark, there was a 6-month window, and we never thought our patients would tolerate that. They could barely tolerate the 3-month window, and so 3-month is standard. And many times we're essentially trying to operate almost 3 months to the day because people are anxious to get into have the abutment come through.
Okay. And then once that part is healed, there is a second part of the surgery where the opening or the aperture is created. And this is where, as a plastic surgeon, you really shine. And you have that abutment that's put in there. And that's basically, guys, that's the little part that you see sticking out of the skin. So tell us a little bit about, because I mean, as plastics, that is where, again, you shine for the osseointegration.
Yeah. So, well, I'm totally biased. So I think we shine throughout the entire thing.
Yes.
One of the reasons for that is that I think there's a couple different concepts, and we have some pictures that we can kind of help demonstrate this. But oftentimes the way I'm thinking about this is at the first stage, what we're trying to do is thin the soft tissues and get rid of a lot of the soft tissue excess. Yeah, well, here we can talk about it, but a lot of the soft tissue excess, because motion in this situation is not your friend. And so what we'll frequently do, and I did this yesterday, is we'll do a thigh-plasty at the first stage to try to tighten the soft tissues, put the implant in, put bone graft on the, at the end of the implant. I think that's one of the keys to making this safe and making this work, is that the implant is essentially buried within biology. It's buried within bone. And so then we'll tighten up the residual limb. And then at the second stage is where we fashion the platform and then thin the skin to have it come through the end of the bone and out the skin. And so
Okay.
that's the general kind of thought. And we can kind of get into some of these concepts. Do you want me to talk through? Is it helpful to talk through a little bit of this to give a background?
Yes. And I was
Perfect.
just trying to look for the right picture that perhaps this one would be a good picture to start with.
Yeah, so let's go back to the beginning, and because there's a couple, I think, key points, and then the most fun part of this is just opening up to questions.
Absolutely.
And so let's start with this slide. If you can just make that slide big. Yeah, perfect. Yeah, so this is something that I feel very strongly about, is that as someone who's been kind of an early adopter of osseointegration, it's interesting or kind of funny to me that osseointegration is as polarizing as it is. If you get on, and I don't spend a huge amount of time on social media, but my general sense of social media is that there are huge proponents and huge opponents of osseointegration. And the reality is, I think, I don't know that it's worth all of that kind of all of that energy. I think osseointegration is purely a tool. It's not a perfect tool, but in some cases it can be a game-changing tool. I think where I think where some of kind of the negative feelings about osseointegration come from is when it's thought of or pushed as like the only tool, right?
Right.
And I think if you generally use osseointegration as one tool and here I kind of use an umbrella, but you can think of a toolkit of a variety of different tools that you can apply to various different problems to optimize function and minimize pain, then I think there's no reason to feel so strongly about it, right?
Absolutely.
It's just a technique, right? And I think that some of that negativity is where it's getting kind of pushed back, I think there's a group of people who feel like it's getting pushed on them. And so these are generally the things I think about when I'm taking care of someone with limb loss. And so it's basically, how do we make that soft tissue envelope as good as possible, recognizing that a socket, if we're going to use a socket-based strategy, is the socket presents kind of as hostile of an environment as there is to soft tissues, right? You were never meant to, if you're an above knee amputation, amputee, you were never meant to walk on the soft tissues of the thigh. Likewise, you're trying to control your prosthetic through your femur, but between your femur and the socket is muscle and soft tissue. And the more you have, the harder it is to control, the harder it is to suspend. So there's a lot we can do to try to work with that. Sometimes people are missing soft tissue, and so if it's skin grafted or tethered or abnormal contours, we can kind of address that to make a socket work. But the ultimate strategy from a soft tissue standpoint is to just bypass the socket altogether. So there are times like when I referenced our patient where I did 70 hours of surgery, that was about moving chunks of largely skin and fat from other parts of his body to resurface the knees, resurface the ends of the limbs. Sometimes osseointegration offers us an opportunity to just not do any of that and just essentially, because we're doing that to be able to withstand a socket. If we bypass the socket, then sometimes we can skip that. Obviously, from a prosthetic function standpoint, there's no question that you can suspend better and control your limb better if it's directly attached to the bone, right? That's from control and suspension strategy. That's a much more natural situation than trying to use a suction cup to hold the limb on, right?
Especially for our folks who have a really short residual limb.
Absolutely. And then from a pain management standpoint, I don't tend to think of osseointegration as a pain management strategy unless the pain is due to the socket, right? And so we use a variety of other strategies. But if there's specifically a pain that's attributable to the socket, sometimes in an above knee level, that's because there's a brim that pushes on you or something like that. By getting rid of the socket, you get rid of the pain. And then the aesthetics is an interesting one because it's something that people don't really think about. It has become more and more of a thought as you get rid of the liner and socket, right? The socket, is a great kind of tapestry for some sort. Everyone gets to kind of show who they are with kind of the designs on their socket. Once you get rid of that
Right.
socket, the soft tissues are out there, and they're going to go where gravity goes. The reference I make, because I do come from a plastic surgery background, is that people laugh at this, but I think everyone understands this. Like, a breast and a bra is like perfectly shaped and in the perfect position on the chest wall. You take away the bra, gravity will do what it does, right? And a liner and socket are the same concept, right? And so, interestingly, I think there was this thought that, oh, if we're not dealing with the sockets anymore, we don't have to think about the soft tissues, right? Because we're just bypassing them, except that we're no longer controlling them. So it's something I call loss of containment. And that's where some of the aesthetics and some of the problems that come from just having the tissue not suspended present. So.
And I have to say, I've seen some and I can only describe them as aesthetically pleasing thigh-plasties done, especially after the person. I'm thinking of one gal in particular, her Instagram tag is Slim Ginny. And she's actually works with Integrum, where beautiful, beautiful lady. And she had the OI done, and naturally her soft tissues were molding and shrinking a little bit more. So she had the thigh-plasty to kind of tighten everything up.
Yep. And I know her plastic surgeon.
Looks fantastic.
Yeah, I know her plastic surgeon.
Yeah, so it's wonderful. We have a question coming in, so I'm just going to kind of read through these questions here. Susan was saying, how would you do this for a below-the-knee amputee?
Yeah, it's interesting. So right now it's not FDA approved for a below-knee amputee. Clearly, I think below-knee amputees may be the most common level of amputation, and so I think it's a tool that we want to be able to apply to a below knee, and it certainly has been. It's interesting because the problems, the challenges of the below knee are different. The bony anatomy is slightly different, and so it presents a little bit of a different challenge in terms of how you get the implant to seat into the bone and stay stable in the bone. But from a soft tissue standpoint, it's actually much easier, because if you think about dental implants, and I think most people, even if they haven't had them, understand what a dental implant is. What osseointegration works very, very well in the mouth, right? Ironically, in the early 60s, when Rickard's father was presenting the idea, everyone, just like osseointegration in the extremity, everyone said, there's no way this works, right? And so it does take us a while to kind of overcome our natural biases about what works and what doesn't. One of the reasons it works really well in the mouth is because the gingiva your gums are very adherent, are very well vascularized. And so that's one of the keys to making it work in the mouth. Well, in the limbs, you don't get that. You either get adherent or you get good blood supply. You have to pick one or the other. And so I can kind of walk through some of those. That's what the intent of some of those diagrams. And we can talk about that, because from a soft tissue standpoint, the different systems have very different strategies. But with the OPRA system, what you're trying to do is scar the soft tissues to the bone, right? So that they don't move, because movement around the implant causes fluid, which then sets you up for infection, right?
Indentation, yep.
Everyone has more movement in their thigh than they do in their lower leg. And so actually at a below knee level, it's, from a soft tissue standpoint, it's easier because the soft tissues are thinner and they don't move as much. And so it's certainly doable. I think we need more data to kind of push into that space.
Okay. And then Dr. Souza, I'm going to just pause for a moment here. So guys, we are doing giveaways tonight, courtesy of Integrum. They are giving away 3 $25 gift cards. So guys, we got some nice giveaways tonight. And what Integrum would like to see is just, what are your thoughts, right? So they want information from you in terms of what is it that you would like to know more about with regards to osseointegration. So I'll be asking 3 questions tonight, and I want you to really post your answers. And this just helps the company of Integrum to help better serve the community. So the first question is, have you personally spoken with anyone that has the OPRA system? So guys, obviously, if you've been on the show, you've been chatting back and forth with one another. But in your daily life as an amputee, have you met someone who has the OPRA system that you've been able to talk to? So just yes or no, throw it into the comment section for me now, please. Pam is asking, what are the rejection estimates?
Yeah, it's a great question, and that's what everyone's concerned about, right? There's just to be totally clear. Oh, no.
No, they're answering the question that I asked.
Okay, I was gonna say I thought I missed the question. No, just to be totally clear, I think the term rejection gets used a lot by surgeons and patients alike. It's really what we're talking about here is infection. Unless you have some sort of unusual allergy to the metal, which is very, very unusual, you're talking about what is the concern for infection, and then really what you're concerned about is what is the likelihood of infection that's going to require you to lose the implant, and then the worst case scenario is what is the likelihood of an infection that's going to cause you to lose the implant and shorten your residual limb, right? And so interestingly, there was an expectation, I think, if you look at the literature, and a lot of this is evolving, because what we didn't have until we kind of did the studies at Walter Reed are really tightly controlled, FDA regulated prospective trials that could give us some of this information. We have that, and the data is just coming out now. Because the problem with doing tightly controlled trials is you have to wait the follow-up period to be able to actually present the data, right? I would tell you there was an expectation that everyone's going to get an infection within 2 years. It turns out that that's not actually the case. What we saw is about 60% of people didn't have an infection, right?
Oh, right.
But certain people had multiple infections, right? And so when I talk about infections, now I'm talking about infections that require either a change in hygiene, like a topical antibiotic, or changing up what you wash the implant with, or we usually define infection by requiring oral antibiotics, right? And so the reality is superficial infections, i.e. kind of infection of the skin that requires you to take an oral antibiotic, are fairly common, but actually less common than we would have ever thought, because there was an assumption that it's going to happen to everyone. It's just a matter of time, right? In terms of the deep infections, the infections that would require you to go to the hospital, get IV antibiotics, or potentially lose your implant, it's much, much less. Since I've left Walter Reed, I'm a little bit out of touch with, well, I'm not out of touch at all with them, but I can't reference the most recent data. But I know that there's a very small number of implants that have had to be taken out, and it's certainly less than a handful. And we're talking about more than 120 implants. And so I would just ballpark we're going to get more and more information about this, but I would say that there's likely probably somewhere in the ballpark of a 5% chance of, and I just want to be totally clear. The data is evolving, but I would say there's somewhere in the neighborhood of a 5% chance over a 5-year period that you'd have a deep infection where you may need to lose the implant. Now, so that's not 50%, right? But it's a real percentage. I will tell you anecdotally that most people who lose their implants want their implant as soon as they can get it back in, right? Because they've seen the functional benefits of what osseointegration offers. Luckily, what's incredibly rare, and I haven't actually experienced it or know of someone kind of in our patient groups who have needed it, is the need to shorten the limb because you've had results, right? Okay. And so generally, it would be an unusual situation. And I think this speaks to some of the advantages of the OPRA system, because it's a relatively small implant. The implant does not extend up the entire femur. It would be a relatively unusual situation where you would get into osseointegration, and then you'd have to be in a small minority of people who then have an implant that needs to come out, and then a very, very small group of people who are worse off because they've had osseointegration. Does that make sense?
It does. Absolutely. No, and I've seen it again for me anecdotally, just on social media, the folks who post regularly about their osseointegration experience, specifically the OPRA. I haven't really followed up too much with folks who have some of the press fit systems. It just came to mind one person who was perhaps going to have perhaps was suspected of having an infection. And she stated, guys, if I have an infection, I have to have this implant out. I will get that infection cleared up. And as soon as I am medically cleared, I want it back because it changed my life, and I cannot, this is the only way I can walk.
Yeah. And that's a fairly common experience. And the reality is that was an experience that was being reported before we ever did this in the United States. I remember I gave a talk when I was a junior resident at Northwestern about this, and there had been like 40 cases done nationwide. And of the handful who had lost them, essentially all of them wanted it back.
Wanted it back. And it says a lot, because this is not for the faint of heart, guys. And I do, whenever I've done a talk on osseointegration, I do want to make it clear. It's several months to a year of surgeries, 2 surgeries, and rehabilitation protocols that are incredibly strict and that need to be followed. So this is not just a quick in and out procedure. This is a commitment, an investment into your health and time. So it's not to be taken lightly, but so that should obviously speak volumes where folks who've already been through that process want to keep it. Benny is asking, is there an age limit? So we get this question a lot. So the textbook will tell you anything between the ages of 22 to 65. That is the optimal age. But as Kurt says, there's like a little asterisk to that. Because I had one patient, he was 75. And he was in better shape than some of the 20-year-olds I know. And he was considering osseointegration, and he would have been potentially a good surgical candidate. So Dr. Souza, what's been your experience?
No, and I've done people certainly in their mid 70s. And again, it depends who you're dealing with. You know, there are plenty of 70-year-olds who look like they're 50, right? And act like they're 50. And so I think that's totally reasonable. I think you want to think about bone health, and you want to think of, so there's a consideration of bone health, but we can kind of get a good sense of that with just the CT that we would get routinely with everyone. And then the real issue comes down to insurance. Right. It depends on how closely the insurance companies are kind of looking at the PMA, essentially the FDA approval, and whether or not they're going to say, okay, you're outside of the PMA.
Recommended.
Yeah, I haven't had that experience so far, and I'm hoping not to.
So let's go back to that. Who would you consider to be a good candidate for osseointegration? And you have, by the way, if you want me to go back to some slides, I'm happy to go back. So let me know if you want me to reference some of your slides, because it's a beautiful slideshow that you put together.
Yeah, I can. So I'm just going to jump on this last question because it's a while we're talking, and it speaks to candidacy. So the idea is that Emily asked about whether or not does it have to be done at the time of the amputation or later? No, it certainly can be done later. And in fact, I think it would be a fairly rare situation where you would want to do, or where I would feel comfortable doing OI at the primary amputation. The reason for that is that, I use this line, I say that kind of osseointegration is a trade-off, not a solution. And the reason for that is because a solution implies that there are no problems, right? And the reality is with osseointegration, there are new problems, right? It's just a matter of what you're trying to do is trade functionally limiting problems or problems that really severely impact someone's quality of life for problems that may be annoying, right? And what is that? That can be drainage, that can be irritation at the skin penetration site, some of these things. And so the title of that talk, and it's essentially a talk I walk my patients through when I see them, is happiness equals reality divided by expectations, right? So the problem with doing this at the time of an initial amputation is no one has ever experienced the limitations of what a socket provides, and there's plenty of people who do perfectly well in a socket, right? And there are a number of surgical strategies that we can use to optimize a socket and make a socket work where you're not taking on the added risk of having a piece of metal sticking through the skin, where there is a risk of infection. So it turns out that risk of infection the infections associated with osseointegration are less severe and less common than we ever would have anticipated, but there is that risk, right? And so you want to, it's a trade-off. And so I certainly believe it's worth trying to make a socket work before getting into OI. Now, I think there are certain situations where it would make sense. If you have a very, very short residual limb, that might make sense. If you have challenges with your soft tissue envelope, where you have essentially no soft tissue. I have a patient we were just talking about prior to the show that has an entirely degloved limb, right? There is no soft tissue to work with. That's a case where osseointegration actually is a way to get to a good functional status without having to do a tremendous amount of surgery to restore a soft tissue envelope. So
right.
So to kind of sum it up, and I'm not very good at kind of being concise, but there's two groups of people I think that benefit from OI. There's people who can't make a socket work. They've tried, they have terrible soft tissue breakdown. They're too short to get reasonable control. They're spending 10 minutes getting the socket on, donning and doffing. Those are people where I put them in the camp of, they've tried, they just can't make it work. That's where osseointegration is a major game changer, right? Because there's nothing more rewarding than having someone who is otherwise now relegated to a chair, and osseointegration unlocks them being out of that chair. The other group, and probably the more common group, are people who, and I just talked to an insurance company for an hour today to get a woman approved for this, she has a transfemoral amputation. She's been making it work. She's a super active hiker, but she has irritation from her soft tissues because she uses her socket so much, right? She is very, very active. She's an avid hiker. And has issues with control with the socket, especially on irregular ground. And the brim, the length of her socket required to get her the suspension she needs is very limiting in terms of her range of motion. So really, what she wants is a higher quality of life, right? That's the group of people who say, yeah, I can make a socket work, but it takes a huge amount of mental energy and physical energy and time to make the socket work. And, if I can just bypass that but if I can bypass that, you can unlock a higher quality of life. That's another kind of rewarded camp. And right now that's mostly at a transfemoral level. What I'm excited for is work at the transhumeral level, because we have done an early feasibility study at Walter Reed where the results are amazing. Again, we have to wait to show it.
Right.
And then certainly we talked about thumb, but a below knee level too. I think I can oftentimes use surgery to kind of make a socket work, but there are certainly patients who may benefit from osseointegration at the below knee level too.
Well, and then the other thing that as I've been working with Integrum this past year and just really seeing some of their patient models, and guys, this is just my own opinion on this. I think it's a really fantastic option for bilateral above the knee amputees. Just working with them over the years, the technology has improved in terms of obviously microprocessor knees, which is huge for bilateral AKs, but those sockets, holy cow, when you have a bilateral AK, even if it's someone who's very slim with a long limb, I mean, it's these two plastic sockets. Right. And then, so for me, I had the pleasure of getting to know Susan, and I know I can talk about Susan because she's been on the show and she's given me permission to talk about her particular journey, but she's just amazing. She's a bilateral above the knee. She's been through it and back. And just the freedom that I see in her movement from having this and not having sockets.
Yeah. I agree with you. I think that's a great case. And it's one where, one of the advantages of osseointegration is the fact that because you're suspending your prosthetic through the bone, you actually get a sense of you can
proprioception
feel when you touch the ground, right?
Yep.
And it's not, just to be totally clear, it's not proprioception. It's not like it feels normal or where you are in space, but you get feedback that you otherwise don't get through a socket, right? That feedback becomes incredibly important when you have a bilateral amputee situation, right?
Yeah.
And so we have a patient who we've been addressing. Again, one of the things that we try to do is, my goal is not to do it the most osseointegration in the world. It's to have it be done well and have patients have good outcomes. So we have a young guy who he wants to just coach his kids' little league team, right? And he's been trying to make it work with sockets. There are some things we need to do related to why he had an amputation, where we need to optimize some of his medical issues, but they're modifiable things. And then I think we've already done that. And so now we can get him into a position, and I'm excited to see kind of what he's able to do.
No, and I remember in one of our pre-interviews, you mentioned about how it's just a tool in our toolbox. And I know from a physical therapist standpoint, now for me, when I see a patient who has very short residual limb, like complicated skin, like a lot of burn or grafting on the skin, or someone who's a bilateral AK, I think, okay, not that I'm saying this person should get it, but this is certainly someone that I'm going to be watching very closely to see if they're a good candidate.
Yeah,
and I think
they, yeah, there's the other thing is, as I haven't experienced limb loss, and so I don't know what it's like, but I remember we had a bilateral transfemoral patient who was incredibly functional. And early in our experience, we kept talking him out of osseointegration. And then finally, where he kind of helped me to understand, he said, you know what, I get it. I'm tired of waking up every day and putting on rubber pants. And at which point, rubber pants, don't do that. But I get, like, there is a cost to making sockets work, where that unless you live that life, you don't totally appreciate it. And I kind of have come to appreciate it secondhand, but not firsthand. I want to quickly answer this question: is a high risk of possible femur fracture?
Yes.
Oh, no question, no question. I mean, because you have this is like everything with osseointegration. One of the really hard parts here is that what you're comparing it to in terms of I don't know that anyone knows what the rate of femur fractures are in people who don't have osseointegration, who have, say, a transfemoral amputation, right? This is another thing. It's been challenging to kind of engage with the FDA, because every single infection they compare against a control group of socket users that they assume have no infections. But anyone who's worn a socket knows that you're at higher risk for an infection because you're in a moist environment with wounds, right? And so, but if we're going to kind of compare it just generally, I'm speaking to this higher risk. I don't know actually if you have a higher risk than someone who doesn't have an implant, but there's no question you now have a piece of metal that's in your bone. The metal is stiffer than the bone. And so if you were to fall directly on your implant, there is what's something called a periprosthetic fracture. And we see the same thing with hip implants, total knee implants. Anytime you have metal next to bone, you have a stiffness mismatch that sets you up for a fracture. The only time we saw it in our patients at Walter Reed is in kind of higher energy, higher demand things like falls from a bike, right? Which it's hard to know if someone falls off of a bike and they're, in a socket. I guess the socket may be protective, but there is some degree of risk. That's not my major concern as we kind of talk to someone about osseointegration, but it does warrant a conversation about what activities kind of are you best suited to do, right? And we had there was just a great meeting that Joe Shu hosted in North Carolina, and there was a lot of talk about kind of people's activity after osseointegration. And the reality is, people are going to. There's Carlos. I still want to fix your arm. I think I said that last year during this. There is, it's one of these things where people are going to do what they want to do. And I think it's to some extent we should encourage it, though we don't know what the risk is, right? But so you have people who are pushing the envelope and doing higher demand activities than we would recommend. I think activities where there's a lot of impact or a lot of torsional motion, I think is problematic. The patient that I feel like we're best suited for is the patient who wants to do activities of daily living, walking, hiking, swimming is something that everyone's always concerned about, actually, but we have a lot of swimmers.
Yeah. Yep.
And that's not something that's something we should probably dispel, is that wanting to swim is not a contraindication to osseointegration. You can either use a kind of an occlusive liner to protect it, or just a glob of kind of Vaseline.
Vaseline to kind of protect the area. Yep. And then avoiding, I think the only one that was contraindicated was the hot tub, which honestly, those things are cesspools of bacteria anyway. So.
In Ohio, we have lots of brown water. I think the clearer the water, the better. But the reality is we don't totally know what's possible. I think that's a place where we're trying to put more and more energy into understanding.
Limkind Foundation, we got Rob coming in from Ethiopia to say hello. So thank you, Rob. We've got one of your fans there, Carlos, there for Dr. Souza. And Glenn, obviously Glenn has been someone who's had a very successful experience with OPRA. And he's saying, talk about the safety features of the Axor. So he's got it behind.
Oh, I think you froze there. Did we lose the whole thing, or just lose Cosi? Can you guys hear me? Okay, I guess we're on our own. This happened. I was giving a talk with Dr. Potter for Ukrainian surgeons, and we lost our hosts, and then it was just me and Potter trying to use Google Translate to challenge these questions. And so we were talking about the Axor. So to be totally honest, that's a question that's better served for your prosthetist. The way to think about the Axor is that it's essentially the bindings for your skis, right? And it's designed to release your limb before you have an injury to, before you fracture or have an injury to the implant. And so there's a tremendous amount of energy put into the design of the Axor. There's constantly modifications of it. There's room for improvement, but I'm, as a surgeon, not the best equipped to kind of talk about the nuances of, what the Axor can offer. All right, we'll just fire. So let's fire some other questions out. Anyone want to hear about the differences between PressFit and OPRA from a soft tissue standpoint? Am I talking to myself? Sure. Oh, of course I offered that, and then Cosi has all the images. Okay, let's tackle this, and we'll see if we can we'll tackle that when she gets back. Okay, is there a weight limit? Yes, there's a weight limit. We seem to continue to try to push that weight limit. I think it's worth an individual conversation with your surgeon to get a sense of what that weight limit is. There are device specifications. I will tell you, there's no question that kind of there's at a certain weight level, you're putting more stress on the implant. There's also the consideration that usually at a higher weight, you have kind of thicker and more soft tissues. And so it presents some unique challenges. But one of my strategies has been to really be aggressive at kind of thinning the soft tissues and essentially making a skinny limb before we get into OI. Weight limit, should we be concerned with discharge? So Glenn has the question, should we be concerned with discharge? It has a lot to do with discharge in and of itself. I'm not particularly concerned with. It's with the OPRA system, if we can get to a really stable soft tissue interface that's not moving a lot, there should be very, very little discharge. If you haven't achieved that, you're going to have more discharge. Discharge in and of itself is not overly concerning unless you have kind of a change in the quality of your discharge or it's associated with pain. So those are the things that I'm thinking about when it comes to discharge. How do you find someone to do it? That's a great question. Here's the way I would kind of think about that. The reality in one of the slides that Cosi has says that this is 80% plastic surgery and 20% orthopedic surgery. That's a line that my orthopedic partner uses. The reality is this is 10% surgery and 90% prosthetics and rehab and therapy, right? And so if you're going to embark on this, you need to do it with a team. And that team doesn't have to be as extensive as the team we have at Ohio State or Walter Reed, but you need to do this in a place where you feel supported by your prosthetist, you feel supported by your therapist, and then you have a surgeon who actively communicates and engages with those team members. And so this can be done. I will just tell you, I think that when I talk to my patients about it, I have said that the two things I have found most challenging are distance and obesity or kind of heavy weight. Both can be overcome. It just requires more work on the part of the surgeons and the patient to kind of overcome those challenges. And so this can be done remotely. There are some very good programs who are able to kind of care for patients remotely. But I do think we want to get to a point where you have kind of robust programs throughout the country. And we are working on, I think there's a growing number of people who are really engaged in this and want this to work, regardless of whether or not, like, for instance, if I did your osseointegration surgery or someone else did, I want it to work for you. And so I'm happy to take care of you. And if you're closer to me, I'm happy to do it. And I think there's a number of like-minded teams and surgeons out there.
Absolutely. I'm back. We got this thing working again. Guys, I'm going to go ahead and post the link here for the Integrum website. Lots of really great information here. Also, if you are somebody who is interested in osseointegration and you're just curious to see, am I a candidate, or this is something you've been thinking about, they have forms that you can fill out here. And I am also happy to put you in touch with the team as well. I did that for a couple of you this year already. Harsh is saying Army is back. Pastor Dave is like, uh-oh, she's back. What do you mean, uh-oh, she's back?
So
all right, guys. So I'm not sure. Go ahead. I'm
going to jump in to answer Pam's question.
Yes.
Pam, obviously this is a gratuitous self-endorsement here, but Indiana is not far away. And so happy to kind of do it and get you connected with my team. There's a thing about kind of looking through the process can you go over the process from initial insertion? And then is there can we show those? Do you have the access to those slides?
Yes.
Yeah.
Let's see. Okay. Is there a particular slide? I'll slowly scroll through, and if there's one that you want me to.
Yeah. So so as you can hear, let's just start with that kind of where it says bone in gray, and I'll just click through this real quickly.
Okay.
This was the line I just referenced. This is Joel Mayerson, who's the chief of orthopedic oncology at Ohio State. And this is the 20% ortho, 80% plastic surgery. The reality is the bone part is important, but the soft tissue part is what's unusual about this. Keep clicking forward.
Okay.
This is the whole thing, though. It's really about, and the way we work at Ohio State is, if you have a PT team and a prosthetist who are interested in this, we can support you remotely. And I know there's a number of other centers like that. Let's go to the next, but that's the biggest piece. What you should not do is have this implant put in and then be told, or then think you're going to find your PT and then find your prosthetist.
Thank you.
Yeah. In fact, and just to throw it out there are centers that will offer that, right? The reality is, if you come see me and we talk about osseointegration, the next, and I view this again, what we're trying to do is get to a good outcome, not try to get an implant in your leg, right? And so for me, it's a process, and I sell it as a process, and it's a process that we wish could go faster. But I usually talk to my patients about, this is going to be a year-long process till ideally you get into the point where you're ambulating and getting and seeing the benefits of osseointegration. When you come to see me, we talk about it. Then you see my physical therapy team. You know, if you don't have a prosthetist, we can get you connected. But oftentimes our patients seem to come with a prosthetist, and then we work just collaboratively with that. We tend to also, then you see my orthopedic partner. And the other piece that we have you see is our rehab psych team, which is a piece that we had at Walter Reed, and I found incredibly important. And I think our patients have found incredibly important. And it's not about screening you for like psychiatric disorders. It's about making sure all the elements of the team are communicating in a way where we all understand our goals, and we're communicating effectively about kind of what we're going to get to. Then we do the first stage. And so, like yesterday, I did one of these cases. And then it's basically about I don't know, 6-week recovery before you are totally healed and done and beyond it. At that point, you theoretically can get back into a socket as long as it's not end bearing. But oftentimes, by the time you're through that 6-week period, you're only 6 weeks away from stage 2. So oftentimes patients will just wait, we'll do stage 2, and we really try to do it 3 months to the date, you know, to the extent we can. And then at that point, what we're doing is we've now stabilized the soft tissue. And I'll show you some pictures of this. And it's really about a couple weeks of babying the soft tissues, 6 weeks until you're starting to weight bear and work with your kind of prosthetic team. And then it's a kind of a generally about a 6-week period to get you kind of moving forward. Obviously, there are certain landmarks. If you go back a slide here, go back one more, this one. So before I ever, here, you want to go forward one more? Yeah, okay, back, sorry.
Sorry, this thing, I'm sorry.
Yeah, I'm looking for anyways, before we ever did an osseointegration case at Ohio State, we had essentially clinical practice guidelines for our therapists. That's how important this is. You want to have that in place before you go forward. This here. And so this is something we've also shared with other centers. It's largely, it's inspired by what we were doing at Walter Reed, but this just shows you how important the therapy piece is to the whole puzzle, right? And it's not uncommon that our therapists identify things that you need to work on before we're ready to get you into OI, right? Go back to the one with the big person and the small person. This is a problem that exists throughout amputation care. And it's this idea that the surgeon is like bigger than the other people involved in the care. And, you know, one of the best things that happened to me is I was at Walter Reed in the early part of my career, and I saw firsthand the value. Granted, I had also been at the Rehab Institute of Chicago for a research fellowship and had a lot of access to prosthetists and therapists and physiatrists. But the reality is, we need to change this dynamic, because as I tell my patients, I really only own the part of the limb that's still there. If you're going to be kind of functional or achieve the goals you want, there's a huge number. There's a number of people who need to make the rest of that work for us to get to success. And unfortunately, that's not necessarily all the case. And so communication between the team members is the biggest piece. And so this is a slide I actually use when I'm talking to surgeons to try to kind of change that dynamic. Medicare approval. If you go through, I'll show you some pictures if you get to the Medicare approval. So yes, yes, Medicare is one of the few groups that does not require pre-certification. And we've had a number of Medicare patients have osseointegration. Diabetes is when I was referencing the young guy with the transfemoral amputations. He had well, not to get too in the weeds there. The reality is diabetes is not a contraindication. We want to recognize that you're going to have a skin penetration site that is potentially at risk for infection. So we need to optimize everything else that may otherwise put you at risk for infection. And so we tend to want to have you have a well-controlled diabetes. This is just an example of, when you're having to use kind of ski bindings to kind of deal with the fluctuations in your soft tissue envelope, it shows kind of the challenges posed by a socket. Let's get to the soft tissue piece. Keep going forward.
Okay.
Keep going. Okay, so here, this is basically one of my medical students drew this for me. And so this is essentially the OPRA system here. And so you see the implant is buried in the bone. We back graft it. And so that, everything that exists beyond this kind of spiral part is essentially sealed in with bone. And then this is the abutment that sticks through the skin. If you go to the next, slide. So the beautiful part of this strategy, and to give Rickard Brannemark the credit, when I first looked at this as a plastic surgeon, I said, there's no way this could work. But it turns out it works really well. And the idea is what you're doing is you're trying to get the soft tissues to stick to the end of the limb so that they don't move around the metal. And so, you're trying to limit the motion. The motion is what's depicted in red, so that it gets born outside the femur and not at the implant. And I'll show you what this looks like clinically, and then go to the next slide. And then importantly, because you're sticking the soft tissues to the end of the limb, it doesn't piston. And pistoning is one of the biggest challenges with the press fit device, is that when you have a thick soft tissue, it bounces up and down, and it can create fluid. And so go to the next slide.
Oh, I see. Okay.
Yeah. So this is the challenge. I mean, we're really thinning that soft tissue. And as you can see, this is one of our patients who is at this point, this looks like he's maybe a week to 2 weeks out. You see all that bruising. That bruising means that we've really thinned the skin, but to the point where it'll stick. Go to the next slide if you can. Mm-hmm. And so you see this rim of red. That's not infection. That rim of red around there is because the skin is actually now living from the end of the bone. If it's living off the end of the bone, it's living as a skin graft, which means it's stuck. And go to the next slide. And this kind of shows you the idea. If you hit one, so you see how the motion is all born at the outside of the femur. It's not born at the implant. And you notice he has like you can see right here. Yeah, he has a perfectly dry stoma or aperture, whatever we're going to call it. Aperture, yeah. And this is the key to success, right?
And you can see it right here, guys. Sorry, don't mean to interrupt, but right here you can see like there's a little dimple right there. That means that has adhered, correct?
Yeah.
Which is what it should.
And this is what makes the OPRA system work from a soft tissue standpoint. It just also what makes the OPRA system a little bit more technically challenging, but though it's not overly challenging, but it can be. Go to the next, just for comparison. If you look at, so if this is more the press fit system, just for comparison. And
good. Yeah.
And so you see how, from a soft tissue standpoint, what you're doing is you're saying, okay, we're not going to try to get it to stick. We're going to keep the blood supply to the soft tissue, but we're going to allow it to move. And so then go to the next slide. When you do that, you get a lot more motion around the implant, and then go to the next slide. And then I think that motion in this plane where you can get pistoning up and down is the most problematic. And so go to the next slide. I might have a clinical picture. And so this is the difference.
That's where you see the weepy.
Yeah. And so, you know, you saw how in the OPRA strategy, we're trying to really control this motion with the press fit. That's less common. And you can go to the next slide there. Yeah. And so this is where you tend to have kind of more drainage from this approach. Go to the next.
And that was the first time I ever saw an osseointegration patient. It was a press fit, and my first impression was, oh dear heavens, it's infected.
Yeah.
And then they tell me, nope, that's normal, and I go, whoa.
Yeah. And so here's another. This is a different system, but watch if you hit the slide or hit the. You see that motion. So this is a patient who came to me and was done by a very good surgeon elsewhere. But that's not, you know, that skin motion is really problematic and is a setup for infection, but also causes pain. And so one of the things, and this gets to a different talk, is one of the things we're trying to do, and you can cancel it now, is I think all the systems are moving to a little bit more thoughtful management of the soft tissue. Again, I think there was a point where we said, well, or globally people said, well, let's not think about the soft tissue, but I think we're realizing how important it is. Again, that comes with all the benefits of being a plastic surgeon.
No, absolutely. And again, that's the first thing you see, you know, and it's the first thing that people notice is what's going on there and why does it look that way? Guys, we're going to do the second giveaway, and we have a few more people on the show right now. So guys, really, really need your input. This gives my sponsors great information on how they can continue to better serve you in the community. So this next question is, what is your hesitation about getting osseointegration? Okay. And again, this is a very unique question, and we appreciate your blunt honesty on this. So go ahead and type it in the comments section. If osseointegration is something that you thought for even just a moment, what is your hesitation with it? And let me just see if I can't fix that echo right now. All right. So Jody is saying infection. Pam is saying soft and pain. Arch is saying infection. And guys, be honest. Like, there's no right or wrong answer here. Scott says he's afraid he wouldn't qualify as a BK and due to weight limitations. Emily says cost, time, and infection. Thank you, guys. Guys, keep putting this input in here. Keep putting it in here, please. Jeff is saying breakage and infection. I'm hearing my own echo. Are you hearing my echo?
No.
All right, that's fine. I can deal with it. Jeff is saying time also. Benny, age and diabetes. Guys, keep the comments coming. Keep the comments coming. I'm going to pick somebody from the comment section to win a $25 gift card. Glenn's like, none. Got it done. We're good.
Oh, I'm interested in the mobility one. Is that a positive or a negative?
Now, here's a study. Again, total PT nerd here. I would love to see the activation of muscles. Put some EMG measurements on the quads and the residual quad and hamstring and glutes, and just see how much more activation is being done with osseointegration compared to traditional socket users. Guys, these answers are great. Oh, you can hear my echo.
Yeah, one of the all of these kind of concerns are totally valid. And obviously there's no question that there's a new and different concern for infection because you have a percutaneous device, and we're continuing to work on essentially understanding how common that is. Right now, a lot of the effort is about how do you kind of decrease the risk from things that are external, whether they're kind of topical ointments or blue light or whatnot. But there's no question. That's exactly what you should be considering if you're taking on osseointegration. Fortunately, the data is again supporting the idea that they're less common and less severe than ever expected. The other theme I'm hearing here is time. No question. This is a commitment, right? I just got an amazing picture from Carlos. Carlos put a tremendous amount of time, and we had some challenges with the soft tissue to kind of get where we needed to go. But to see a picture like that is kind of incredibly rewarding. And so I would say that if someone's going to tell you this isn't a time commitment, you're in the wrong place, right? This is not like you just stop by, get your quick surgery, and then you're done. And I think, I recognize that Integrum is sponsoring this. One of the things I've really, I'm not trying to talk people out of it, but I want people to get the best possible outcomes, right? And I think one of the things I've really valued about Integrum is they want this to work, and they want this to be a good experience for patients, right? And they recognize that it's not for everyone, and it's not to be done as kind of a one-off, because the surgery is easy to do, right? It's the recovery and the rehab and the work to make this work that takes the time. And so it's a totally reasonable. And I've had lots of patients who say, "This sounds great, not for me yet, but I'll get back to it later."
No, and guys, when people ask me, should I get osseointegration? There's a couple of questions that I put back on them to think about. Number one, what is it that you feel like osseointegration will be able to do for you that you are not able to do now? And it's what, Dr. Souza said earlier in this talk. You're trading off one set of pros and cons for another. So you have to understand, are you willing to deal with the pros and cons associated with osseointegration versus the pros and cons of using the socket? Number two, the team approach. And this is something that he mentioned. A few of you have echoed it in the comment section, and I cannot stress that enough. Prior to getting this done, not only do you have to interview your surgeon and get someone who is hopefully as qualified as Dr. Souza doing your surgery, but looking at your surgeon's team. They should have protocols and a team ready to support you. If they don't have a physical therapist, occupational therapist, in case of psychological support, on their team already, that is not the surgeon for you. And if they cannot detail to you, like I'm sure Dr. Souza in his sleep can name the rehab protocols that he puts his patients through after osseointegration, that's like a no-brainer. If that does not exist, and I've heard of this problem sometimes, unfortunately, that is not the surgeon for you, even if it means that you have to go out of your zip code to find a surgeon who is. Guys, thank you again. I'm just going to go ahead and name Jody. You are the winner from the first giveaway. And then Cindy Begley, you're the winner of my second giveaway. So Jody and Cindy, I got one more, guys, coming up, so don't leave just yet. Jody and Cindy, please email me.
A couple quick things. What you really want, though, is to have a physical therapist who knows the rehab protocols better than me. And we, in Jen Swift, we have a phenomenal therapist. I don't know that the threaded bone is harder to remove than the press fit. I actually think it's very much the opposite. And the reality is, if you're in a position where you need to remove the implant, the implant is usually loose. So that should not be a concern. One of the ways to think about this is the amount of bone that's infected. When you have a press fit stem, it's a much longer stem. So you're impacting a lot more bone. Downhill skier. Got it. Good question. Downhill skier. I've done a downhill skier, but it was a transhumeral implant. So it was not an implant she was skiing on. I would suspect the problem with downhill skiing, and actually the patient who we talked out of osseointegration multiple times before he finally made the comment about the rubber pants, is a kind of gold medal Paralympian. My general sense is that it's best done in a socket. Now, it is possible to do high demand activities with osseointegration where you're protected by a kind of a socket that goes over the abutment.
Right.
So I wouldn't necessarily think of osseointegration as a means to ski better or move. It'd be interesting just to see if you think of the angle of pressure when you're because you're basically in a prolonged squatting position. Yeah.
Right. Along with the forward movement
Yeah.
of the femur on the tibia.
So I grew up ski racing. Interestingly, one of my good friends was Bodie Miller's roommate in ski school. But I skied slalom. The problem is there's a lot of torsional movement in skiing, and so I would be a little bit concerned. And I'm not particularly conservative when it comes to restricting people, but I wouldn't. I think it's possible to ski after osseointegration. I would not think of it as a means to like ski better or have better control while skiing.
Well, and we had that conversation with Kurt on the show several times because I'm a runner. So the first thing I ask is, can people run? And obviously that's not a recommended activity at all for osseointegration, but it can be worked around with using a prosthetic for running.
Yeah.
If that's the particular case of the person for.
And we may get there with more understanding and some implant design, but yeah, right now that's not my recommendation.
So again, Kimberly, it goes back to what are you hoping to do with osseointegration that you can't do now? And if you're thinking that it might improve your skiing, then that obviously is not going to be a reason for it. We're having some really good conversations here.
I like this. I like Kevin's comment about the team strategy, how you can fail. I mean, the reality is there's always opportunities. What the team, meaning always opportunities to have a challenge. What the team strategy offers you is the best safety net when you have that challenge, right? And so this is one of those things. What the team concept offers or suggests is that there's a long-term interest in this, right? And the reality is the goal is to have this implant be sticking out your skin for the rest of your life, right? And so there's the answer is I would consider that, depends how fast your grandkids are. But I would consider that an activity of daily living, right? And do people kind of push that boundary fairly commonly? Yes, right? Again, we're still comparatively early in this. And so we're trying to put more thought into learning the limitations. It may be that we're being overly conservative,
Okay. And then guys, I got one more question for you all this evening. This is for the last $25 gift card. And the question is, do you talk about OI with other amputees in your social circle, whether it's in your support groups, whether it's in your prosthetist office? Is this something that has come up in conversation with fellow amputees? Obviously, you're on this show, so that happens here a lot. But outside of the context of this show, do you feel like you've had conversations about OI with other amputees? It's a yes or no. So Harsh is jumping in with yep. Glenn saying constantly, absolutely. Come on, guys. I want to see lots of answers. I got a hot $25 gift card here. Carlos says yes. Scott says no. Pam, yes. Kimberly, no. All right, guys, keep those answers coming. So last question of the night for you, Dr. Souza. What would be questions that folks should ask their surgeons if they are thinking about having OI, if they're interviewing their surgeon?
So if they're
top question.
Well, I guess that it's hard to kind of encapsulate that in one question. Yeah, prosthetist. Well, okay, I'm going to answer it like a politician. I'm going to not answer that question. I'm going to answer Pam's question. Yeah, it's interesting. The prosthetist not a fan of OI. Again, you have to kind of ask why, right? And it's just a tool, right? And so if someone's really against it, you have to ask the question why. And one of the reasons is it does challenge the prosthetic model of socket adjustments when it comes to finances. We just have to be honest about that, right? Because there is those socket adjustments to keep making it work that make money, right? That said, there's lots of prosthetists, and I'm not suggesting anything at all about your prosthetist, but there's lots of prosthetists who, like all the other people involved in your care, are just trying to get you to the best possible outcome. And if you can do that with a socket, phenomenal, because then you don't take on the risk of infection, right? Or the other challenges or limitations, right? But if you're not doing great in a socket, why withhold a possible tool to get you to a better place, right?
Usually I find that it's because they don't know enough about it.
Yeah,
That's usually what it boils down to.
And it may be from a well-founded place of being concerned about infection, and that is a concern. But we just need to kind of then understand what that risk is and what it's worth. The VA looked at this a long time ago, and they asked a bunch of veterans, they said, and it's funny because the question was posed as, if you needed to get IV antibiotics and get admitted to the hospital, what would you be willing to trade to do that? And people said, I want to be able to do more things and be more comfortable. That was it, right? And the good news is that's not the common trade. In fact, that's far from the common trade. It's not particularly common at all. I guess, obviously, with any surgeon, with any kind of surgical procedure, and this is a newer surgical procedure, you want to get a sense of how much they've done. That's obviously there's something to be said for experience. But you can have very good surgeons who are just doing this for the first time, but they have all the skill set to do it. That's where, if you have a newer surgeon in the space, you want to make sure you have a team, right? And you want to make sure you have a surgeon that is open to reaching out with other surgeons, right? Yeah. One of the things, again, my goal is not to be the only surgeon doing this or to be the surgeon doing the most, right? And I'm more than happy to, and Integrum has helped me have the opportunity to kind of to teach other people how to do it. And I think that's how we need to make this work. So there's not a specific question. The thing I feel fairly strongly about is that this get done by someone who otherwise takes care of amputee, like the limb loss community, right? That
understands the amputee. Yes.
Because if not, then it starts to look like the only tool that they use to treat amputees, right? And so that's the one thing I would look for as a patient, is I would look for a waiting room full of other people missing limbs, and then and actually the first thing I do when we talk about, in the same way I don't try to kind of jump into saving a limb or taking a limb off, we don't jump into OI. So anyone who's come into my clinic, we look at, okay, what's this limb doing for you? What's it not doing? What are the challenges? And then how can we address that? And sometimes that runs the gamut from, can I take a big piece of skin and fat from somewhere else in your body to resurface it, to replace a skin or a limb that has skin grafts and not enough padding? Can we take away padding to make it thinner to better fit the socket? Or do we bypass the socket? But again, it's kind of a range of tools, and each comes with their costs and benefits.
Absolutely. Glenn says, my prosthetist told me that Hopkins was doing OI. Yes, and actually Hopkins physical therapist, Ed Lyons, was on the show this year. Phenomenal PT, and just good human being. So if you're interested, go back to the YouTube channel and you can see the episode that we did where we focused on the rehab protocols around OI, specifically the OPRA Implant System with Ed. But yes, Hopkins is doing OI. Glenn said his first question before he had OI was, am I a candidate? And then, how many of these have you done? And the last question was, how soon can you schedule me?
Yeah.
Okay. No, and Glenn, I got a chance to meet Glenn at the Amputee Coalition National Conference, and he looks phenomenal.
That last question is always the hardest to answer in my clinic, but we like, this is a priority for us, actually, as is most of our kind of limb loss care.
Yep. All right, guys. The winner of our last giveaway was Jeff Zeller. So Jeff, guys, those of you who are winners, Cindy, Jody, and Jeff, please email me your name and address so that Integrum can send you the gift cards. Guys, this has been like a record-breaking show because you guys kept us talking. So that, to me, the longer the show lasts, it's just a mark of a good show and a good speaker. So I do want to take this time. Dr. Souza, thank you so much, not only for your service to our country, but thank you for the service to the limb loss community, and all the information and the time you took from your life today to give us this information. So thank you very much. And then Integrum, this is our last show for 2023, right? But we will hopefully be seeing Integrum again in 2024. And I just want to say thank you so much for the support. I say it time and time again, I cannot do this show without the support of my sponsors, and I can't do the show without the support of my audience. So thank you to both. Guys, as always, thank you for letting us be a part of your lives this evening. Next week, we have a show with College Park. We're going to be talking about weight management after amputation. Never done a show like that before, and I think it's long overdue. So I think that's going to be a really cool show, guys. So, and next week's show, it's going to be at 11 a.m., not its usual bat time. So guys, with that being said, we're going to wish you good night. Thank you. And we'll see you next week. Same bat channel, different bat time. All right, guys. God bless.
Thank you. Bye.